Yeah. Okay, it's 6:03. We're getting a full screen. I think we'll start. So welcome to the spring edition of the Victorian Clinical Network for Abortion and Contraception Care, known as VCNACC. And I would like to start by acknowledging country. So we would acknowledge the Aboriginal and Torres Strait Island people as the first peoples and traditional owners and custodians of the land and waterways in which we live. We honour and pay our respects to elders past and present. We recognise all Aboriginal and Torres Strait Islander people and their ongoing strength and resilience despite the past and the present impacts of colonisation and dispossession. Tonight we've got quite a full agenda, and I have absolute delight at introducing our key speaker tonight, who could just stand up and take a bow. This is Jess, one of our senior social workers, and she's going to talk to us tonight and address quite a lot of the questions that many of you are bringing our way with regard to social work and options counselling. And we also have got a little bit of a session on deregulation, what it means to us, and what we've managed to find out amongst all the confusion in the last week or so. So Kath's going to talk to that. But first of all, we always traditionally start with a introduction and update from 1-800-MY-OPTIONS with Carolyn. For those of you who haven't been here before, if you could just introduce yourself on the chat. Many of you we know, but if this is your first visit, could you introduce yourself on the chat, and then I will say something about that after Carolyn's talk. So over to Carolyn.
Thanks, Patty, and thanks everyone for having me today. My name's Carolyn. I'm the manager of 1-800-MY-OPTIONS, which is Victoria's phone line and online service for contraception, abortion and sexual health. We have been pretty busy this year. We're averaging at least 600 calls a month, and 85% of them are abortion seekers. So it's been pretty consistent for at least 12 months that abortion is in demand, and it's the service that we're supporting people to navigate through and around their options in the sector. We're working with around about 700 or so registered providers on our system across the state. Over 300 of them are medical abortion providers. And that is something that continues to grow, which is great. In terms of the callers that we're speaking to at the moment, around 20 to 23% are rural. Currently, we have around about 5 to 8% are Medicare ineligible, which is always a really difficult group of people to navigate the system for, and international students are the majority of those people who are ineligible for Medicare that we speak to. Around about 70% are under 9 weeks gestation as well. So that tends to fluctuate a little bit everywhere from about 70 to 75% of our callers are generally under 9 weeks. And that's a really great thing because they are potentially eligible for medical abortion, or at least calling us before they're too far advanced in gestation and needing to travel to Melbourne. I thought I'd also share, because we're talking about pregnancy options counselling. Currently, we're getting around 3.2% of our callers are looking for options counselling. It's really steady, and it has been steady throughout the lifetime of the service, with a few little fluctuations, particularly during COVID, where we had up to about 8 or 9% of our callers wanting options counselling, but it's back to normal right now. And whilst the vast majority of our callers are looking for options counselling around the choice to have an abortion or not, we do get a few people, a very small percentage of them, are looking for the counselling services after abortion to help support them to process the experience that they've had. The people who are looking for counselling we can generally find a pathway to a counsellor for them, but we don't have a lot of counsellors on our system. Luckily, the counsellors that we do have are quite well connected and happy to provide cross referrals when they don't have capacity, but we don't have many. And the other issue is that they are private services generally, and so people have to pay for the counselling. We do provide our callers with the information that they need to be able to access a non-directive pregnancy options care plan through their GP. But again, a lot of GPs don't know about that care plan and end up giving them a mental health care plan. But it's just a really tricky space for somebody who is low income and not quite sure which direction to go with the pregnancy that they have. Options counselling is really, really difficult to access. So I'm really excited to hear what we're going to learn today. Thanks, folks.
Carolyn, was there a bit of an uptick during the pandemic?
Yeah, that's when we had the higher percentage of callers who were looking for options counselling. It was really pandemic related, and some of the questions that we were being asked were far more explicitly relating to their concerns about birthing and parenting during a pandemic and attending hospitals. So we were also seeing people more inclined to want to access care, abortion care, in primary care. So generally the default for people looking for an abortion when we speak to them is that they want to go to a hospital. They always just assume that abortion happens in a hospital. But it changed a little bit, that trend during COVID, where people were a bit more accepting that or seeking care through primary care.
And with the current concerns and a lot of media attention, quite rightly, on it about cost of living, have you noticed people talking about that in their referrals?
Oh, absolutely. Consistently, our callers, around 30 to 40% of those 600 callers say that cost is a significant barrier to them being able to access the reproductive health services that they're looking for. And so finding bulk billing options for the abortion is really important, but it means that cost for counselling can be incredibly prohibitive.
Does anyone else have any questions or comments for Carolyn? I just wanted
camera on. I'm Lara. I'm a GP over in Atlanta. Sorry, you mentioned GP item numbers and care plan options. Are you, just so we're clear, are we talking about a 4001, or just to be really specific, because unfortunately general practice is all about playing Medicare game and item numbers. So can you tell me which one do you know which item code we're looking at?
We generally direct people to the Medicare details, and yeah, there's 4001, but there's also the option to provide a referral for non-directive pregnancy support services by a psychologist, social worker, or accredited mental health nurse. They need to have done additional training. I'm sure Jess is going to talk about that. And that care plan offers 3 rebated services within 12 months of a pregnancy. So that can apply both before or after an abortion, or before a choice for an abortion. And so those are services with the counsellors that are on our system. We generally know which one of those are accredited to provide care under that particular care plan, or whether they're not. I can actually drop the link right now to the Medicare fact sheet,
if you wouldn't mind. And did you say 3 sessions? Yeah, 3 sessions.
So it's not always appropriate because there's often a lot of other issues, but then it might roll over to a mental health care plan. So for someone who's already had a mental health care plan and potentially used up some of those sessions, this might be quite useful. But it's also really useful because then they can have this type of non-directive pregnancy option counselling rebated, but then move on to a mental health care plan, which means that they get more care in that year.
Well, that'd be really helpful if you did put it into the chat, and then we could maybe promulgate that through our networks. Yeah, thank you very much. Any other comments before we move on to Jess's presentation?
I just think it would be good, Carolyn, if you can also post that or send that through. We could post that on OzCaps for information for our members there.
Yeah, I'll send you an email, Danielle. I'm not on as OzCaps, so I'll definitely send it through to you.
I can post it if you like, because I'll
Thanks,
put all the information together.
That
Right.
was Kath, yeah,
Yeah.
and then we can, yeah.
Sure. Can everyone see that? I don't know. Good. So are you okay?
Yeah.
Because well, I'll
Just
put,
means you're going to be looking inside. Oh, that's better. Yeah, and then she's using the screen. And then we'll make it. You want to come off a bit because you've got. No, okay. No, very high tech. Thank you. Take it away, Jess. Just to double check, can everybody see these slides on the screen? Can see some nods. Beautiful. So my name is Jess. I'm one of the social work team leaders here at the Abortion and Contraception Service at the Royal Women's. Thank you for having me this evening. Patty and Kath have asked me to come along, I think, for a couple of things, just a little bit of an overview of the social work service at the Women's, but also to be a presence to answer any questions that might have come up that you feel maybe could be answered by a social worker that works in abortion care. And to also give a very sort of introductory snippet into pregnancy options counselling as well. So very open to taking this whichever direction is most helpful, but I'll start going through the slides. So I thought it would be helpful firstly to start off with a bit of an overview of the social work service at the Royal Women's. So we have 4.4 EFT, there's 5 of us. We do a few different things. So primarily we run an intake service. As you can see, we have around about 200 referrals a month, and that's for all gestations. So that's anywhere from very early in the pregnancy up until 24 weeks and beyond. Most of our referrals come from 1-800 My Options, and then if not, either GPs, self-referrals, or other services around the state. We also run, as I'll explain a bit later, pregnancy options counselling. A big bulk of our work is in the post-24-week pathway, so the advanced gestation terminations, and that's primarily where a lot of our funding comes from and why a lot of us are in the role. Within that, as you probably know, the sort of the gist of a social work role, but a lot of it comes down to the clinical support. So for us in our service, we see a very high presentation of family violence, homelessness, reproductive coercion, young people and or young people who've experienced sexual assault or abuse. So a lot of work with docket teams and child protection. Can often involve supporting people regardless of age or cultural background around supporting them to conceal their pregnancy or termination. In the background of that, we've got a big presence in our multidisciplinary team, and we're involved with the intakes for in terms of the bookings of patients and the planning of care. It can also involve basic social works in terms of admission and discharge planning as well. We can do support on our birth centre and support in our day of surgery unit, and we also have a presence. We have someone always sitting in our clinic, so whenever a patient is coming in to meet with the doctor for their consult, there is always a social worker available for counselling or whatever else other support is needed. That's a very rushed summary of what we do, but I hope that that gives a bit of an illustration of some of the things we get up to here. So in terms of pregnancy options counselling with us at the Women's, it is provided by qualified social workers. Some of us have additional qualifications in pregnancy options counselling, or some people have a Masters of Counselling. Some people have gone on to do other therapeutic qualifications as well. Bare minimum though, everybody is a qualified social worker, and that's usually a postgraduate degree. We are committed to confidential, non-directive and unbiased counselling. Generally, we provide it face-to-face, telehealth or telephone. I'd say at the moment, and this is probably a lingering effect from COVID, but easily 85% of it is by telephone. I think it's not necessarily a bad thing because it means that we're accessible to patients as well. It is typically short term. I'd say on average 2 is the maximum that we can offer. Generally it's 1 session. I think if we still haven't reached a decision after a couple of sessions, then there's a bigger conversation to be having. The most important thing is it is optional, and it is not compulsory for any patient to access options counselling in order to access the service with us. It's free of charge to any patient who's eligible to come to the Women's in the first place for their termination.
We are hoping in the long run to expand our service a bit more to be able to cater for patients that might not necessarily come to us for their abortion care. But at the moment, because we are such a stretched service, we do have to limit that to the people that are actually going to be accessing their abortion, if they were to have an abortion, accessing their abortion care with us. So some of the principles of options counselling, and maybe these are some of the basics, but it's always worth going over the principles, is that the number one thing is that is the woman as the expert in her own life and needs. No one else, it is them. They are the centre of the counselling, and they are the centre of any discussions you have about what this pregnancy could mean for them. As I mentioned before, it's non-directive, so it's unbiased, it's neutral, it's non-judgmental, it is strictly confidential. Within our practice here, we don't engage with the partner in pregnancy, so the male that's involved in the pregnancy, and likewise we generally don't have, say, the patient's mother or a patient's best friend or whoever else involved in these sessions. I appreciate that in some of your contexts maybe that might be more appropriate, but for us we're very strict on it just being a pregnant person. And that's due to lots of different reasons. It's probably our hypervigilance in having a really high presentation of family violence and sexual assault. And when I say family violence, that also includes reproductive coercion. So I appreciate in some contexts, maybe it might be more appropriate, but for us generally, and to my knowledge, a lot of the private providers in Melbourne at least don't generally provide it to the partner in pregnancy as well, unless it's assessed as appropriate. And as I just touched on, a strong principle of options counselling is always bringing knowledge of reproductive coercion and family violence. So in more general terms, options counselling provides practical information about pregnancy options. So as you'd be aware, termination, adoption and parenting. It's a really important space, or it can be an important space to explore preconceived ideas about termination, but also ideas about adoption and parenting. It's support to explore all of the pregnancy options, and it's contextualised within the individual's life, their needs, their values. So the Women's has this lovely graphic. I'm not sure if you can see me highlighting on the screen on the top right, but it's about situating the woman within her values, her beliefs, her goals, and those more broader sort of system-based theories around religion, friends, family. But it is always privileging the woman at the centre. And often when we're doing counselling, we're actually visualising this through the session, and we make our way out through that onion, for lack of a better word. And it goes without saying that we always lead with compassion and curiosity. You know, we're often asking the question, what has it been like for you to be in this situation, or what's it been like for you to make the decision to have an abortion as well? I find often it can be, you might get a referral for options counselling, and it can actually just be a 50-minute session of somebody needing to find out what it's like to have a termination. Or it can be a 50-minute session and somebody wanting to find out what it's like to go through an adoption process. So sometimes it is genuinely about decision-making conflict and supporting somebody to work through what they're experiencing in terms of that conflict, but sometimes it's actually fact and sort of initial practical information about their options. So this is some of the basics, but you would initially start with the feelings about the pregnancy. How did you feel when you found out about the pregnancy? How are you feeling now? What did it feel like when you did the urine test? What was it like? What's your initial reaction? It's checking in and their understanding about the basic facts about termination, parenting and adoption. Once we've got those basics and you've got a sense of what the person is needing, it's exploring how does this pregnancy, how do these options, how do they fit within that individual's goals, aims, plans, needs, life stages? That can be the big gist of it. And then it's exploring a person's readiness to commit to that decision. And then at the end or at the start as well, often you're checking in around what information is needed to support this decision making. So what preconceived ideas about terminations do we need to work through? What preconceived ideas about adoption do we need to work through as well? Might go without saying, but it's always important to touch on that pregnancy options counselling should never be intended to persuade or convince a patient to make a particular choice. Should never pressure a person to make a decision in one session. It should never be used as therapy or to replace therapy for other issues. So, mental health or any other issues that a patient might experience. And we are never the ones to make a decision for a patient. And I think this can be really challenging when you're sitting with someone who's in such conflict in their decision making or ambivalence. This is something where you really have to hold yourself back and be very, very self-aware of this, but these are the things that we cannot forget. And I think a lot of patients often will come to us and fear. I've even had other practitioners call up from different services and check that we're unbiased, because they're afraid that we are going to advocate for or try and pressure this person into having a termination. So, you know, sometimes we really have to go back to the basics in terms of dispelling some preconceived ideas. I'll open up to questions in a second, but I just wanted to touch on a couple of resources that are very helpful for both patients and for clinicians, regardless of your discipline. So the Royal Women's has a great webpage, Unplanned Pregnancies, and then there's one called Deciding What to Do. And if you scroll down on there, there's about 3 or 4 different PDFs. This is one of them, Pregnancy, a Decision-Making Guide. Some of our counsellors actually use this with patients face-to-face. For me, I often direct a patient to do it before I meet with them, and that can be really helpful. And it's a sort of sliding scale, and it asks all of those things around values, needs, life stages, readiness. It's a great support. So that's on the Royal Women's website, and we can send that through a bit later on. Other places that we obviously direct patients to are Children by Choice. They've got some fantastic resources on their website and similar sort of prompts and questions, actually in more detail than what we have. And I often direct a patient to go in their own time and have a read through, then maybe have a journal, write down their expressions and their responses to some of the questions. But that is a really fantastic resource. And then we've already had Carolyn speak today, but the number one place I would be directing patients to is 1-800 My Options, for referral and information to where they can access their closest or their most appropriate pregnancy options counselling service. For clinicians, obviously the things that I've just mentioned, but I wanted to mention a couple of other things, which is maybe you've all done it already, but there's 2 training sessions with Children by Choice, and I can't remember exactly, but they're maybe around $50 or $100. Yeah, 50. Yeah, 30. A 4-hour introduction to pregnancy options. I think this is relevant to any discipline, anybody that's working in this area. I really do think it's worth it. And it's also fantastic to be engaging with other people in the area. And I think part and parcel, if you're working in pregnancy options counselling, you do need to have some insight into reproductive coercion and abuse. You know, it's language that we're only just starting to really, or an area that we're only just starting to even formalise in our practice. So I really think you have to do both. And I'm sure that there are a lot of resources out there, and not every resource is the right fit for every practitioner, but we really love this book on the left, Decision Assessment and Counselling Abortion Care. It is American, so you kind of have to take it with a grain of salt, but there are some fantastic scenarios and situations that you can read through. It, you know, it goes from everything from sitting in front of a 14-year-old that thinks that abortion is murder to somebody who's just really struggling with whether or not they want their 3rd child. It's fantastic. You can get it on Amazon, and I would absolutely recommend that one. So that's the end of my ramble. Are there particular questions or areas that people wanted to focus on tonight, or things that I might not have covered? Go back again.
We can close it and then we can see people.
Yeah.
Thank you so much, Jess. That was a really good overview. Anyone have any comments or questions? Don't be shy. One of the questions, I'll ask a question that we get asked a lot when we're going to community health centres, or talking to GPs, or to practice nurses, nurse practitioners, midwives, and smaller communities. And actually also when we're talking to practitioners who are setting up or starting to set up services in a secondary hospital, one of the things we get asked a lot is, we don't have a social worker, how hard should we try to get one?
Very hard.
Yeah. Would you like to ask the question?
Very hard, I would say. I was actually having this conversation with somebody today from another major practice in Victoria, and we were doing a handover of a patient, and she said, "Oh, just out of interest, we worked out that she's the one that's trying to get social work service starting in her hospital." I think you sort of opened the floodgates, and it's probably the same with all disciplines, but I'm sure Carolyn can speak to this as well. But the stats that we know, part and parcel with reproductive coercion and seeking termination care, we just need it. You need it. You need it to support people to safely access abortion care. I appreciate that there's nursing and there's surgical aspects to safety of care, but there's absolutely a social component to this.
So could I
well.
just get you to clarify that you're talking about a hospital-based service?
Hospital-based
Yeah.
service, yeah.
So absolutely, we should be advocating for it, because I certainly have had that experience of being involved in the services at the Austin that still doesn't have a social work input, and how difficult that was. But the other thing that I really liked about your talk was that, you know, for the likes of Morwell or Bairnsdale or Maryborough, that there is a basic tool that you are showing us, and a basic approach and some resources that any of us as clinicians could start talking to patients about, you know, the difficult questions. Rather than thinking, oh gosh, I've got to find them somewhere to go to. So there's the two.
Yeah.
It seems to me that you're talking about the two things here. Is
Yes,
that right?
correct. Yeah, both things. Yes, definitely. And I think Patty, you recently shared an example of our service before you had social work running intake.
Yeah.
And that we would find that a lot of I wasn't here, but you would find that a lot of the psychosocial issues would declare themselves on the day of surgery, on the day of their appointment, and you would then spend 4 hours with this person doing X, Y, Z. Whereas I guess the model of our service is that we, within social work, we have screened for decision-making applicants or conflict. We have provided the options counselling. We have screened for family violence or what have you.
Absolutely. Yeah.
Well before. And of course that's extra work, but that's what we're here and we're staffed for. So it means that on the day that they come for their care, it might still be a work in progress, but we know what we're expecting and we know how to support that person.
Yeah.
But yes, the options counselling is a big arm of our service. And it's really important to have it formalised as well. I can imagine it can be really overwhelming if you don't have it formalised, and each caller you're making is spending an hour and a half on the phone with each person just to do an intake. So to be able to have this sort of arm of us where it's formalised and there's separate time and it's boundaried, that's very important for us.
Would anybody like to comment on their experience of yes, Lou, please, I'd love you to comment.
Hi everybody, Louise Holland here from Bendigo. I suppose there's a couple of things I'd like to just comment on. Thank you very much for your presentation. It's always really wonderful to have that detail. I think one of the things that would be very interesting in terms of advocating for the sexual and reproductive health hubs across the state, now that quite a few of them are going to be introduced, and now we've got quite a few that have been working for a long time and obviously got some experience, is also being able to potentially nominate the staff who work in the hubs who've been experienced in person-centred pregnancy care options counselling to be potentially someone that they can be referred to. So one of the things that we've often done is that we've actually had GPs within our practice who potentially do provide the support for early medical abortion, but they've often referred someone or someone to come in to see us and see one of the experienced nurses for a session. And I think that's really some untapped experience and talent there. So I'm not a registered psychologist, I'm not a mental health nurse, but I've been working in this field for a long time, and you know, since the inception of us being able to support and provide early medical abortions way back when, we've kind of developed over the time a capacity to do that, and certainly doing some mental health support in regards to disenfranchised loss for women, that also comes into that as well. So I just think, as a comment, that might be something that, you know, hubs can be supported for their staff to be you know, supported to do the education, because, you know, in Bendigo we have a counselling team. For many, many years, we've tried to attract a social worker, a psychologist who'd be interested in this being part of their portfolio, and haven't been successful. So they'll do general anxiety, depression, they'll do grief and loss, but they won't actually specifically do it around reproductive health. So that's just a curiosity and also a reflection of what actually happens out there in kind of regional GP land. Yeah.
Yeah, I think that really ties into, you know, Jess's comments about this, that there is an approach, and there is, you know, there is resources that people can tap into rather than feeling that they're not suitable when they're absolutely imminently suitable because they're local providers who may often already have a relationship with that person. You know, might have seen them for vaccination, seen the kids, all of that sort of thing. And just, I love the way you mentioned the hubs and that idea of having, you know, there being like I keep using the term super hub Louise, you know, like where there's a hub that has had lots and lots of experience, and there are people such as yourself with that advanced, you know, hybridized experience and ability to do options counseling, and that could be the source of teaching others, you know. And that's one of the things that I think we can say that we're trying to get funding for our hospital, that we might be able to develop an educational arm, a bit like the Children by Choice one, where we could support the hubs a bit more, and then the hubs teach the others, and on it goes, so that there are more people that will be willing to sit there with the patient when they have those, you know, difficult conversations, rather than having to organize an external provider. And I guess the other thing I would say is that, as Jess said, that, you know, we were funded since 2019 specifically to do the work from 18 weeks surgically right up to 24 and beyond 24. And that's the group that our research is showing has got, you know, maximum numbers of patients with ambivalence, drug and alcohol problems, coercion, background childhood sexual assault, physical assault, disenfranchised patients. And so it's appropriate to be really social work heavy and have a lot of social workers, and we need more actually here. But it's a different demographic than might be choosing to have a local MTOP in Shepparton, you know, because someone with those complexities or that later gestation, we're happy to see, of course. If that makes sense, we're not really trying to tell others that everybody has to come to the big hospital. Yeah, it's the absolute opposite of that. Yeah. And am I right in saying, Jess, that and Kath, that in more recent months there's been more and more requests about, you know, wanting education around options counselling and you know, advanced practice in this area? Yes, absolutely. Yeah.
Within Melbourne and then within the whole of Victoria, absolutely. Yes.
And that's a tribute to yourselves, and it's also a really good symptom of the fact that more practitioners are coming online, and there are several secondary hospitals that are really now starting to really try and develop their model so that they can start in the next year or so. So it's good.
It's an exciting time. Yeah.
Any other comments or questions? Don't hold back. Anything in the chat?
Yes.
Danielle saying, can
Yes.
you post the title of the resources in the chat? Is
Can do
email?
that.
Yeah.
I can email them.
And will we then email them to everyone who's been there tonight?
Yeah, I was thinking I could send them through Sophie.
You can send them to me, and I can
that's a really
send the
good
links and the
idea.
info, and I can send a follow-up email this week. That's fine.
Oh, there's Heather there.
And there's some other options there online, the 1-800 page.
Yeah, I think just the last thing I'd say, it is very important that you do, if patients start coming to the women's, for instance, and it's not available in your service, and you're directing them to 1-800 My Options. That's the most important thing, because I have encountered patients that have gone to a psychologist or a counsellor or a social worker that they found online, and it's ended up that person isn't a safe person for them to be seen. So if you can go through a service, if you can go through 1-800 My Options, that's the best thing to do. It's just happened too often that someone has sat down with somebody and they just stop. Not helpful, not a safe person for them to be speaking to. So
This adds the trauma.
yes, I couldn't recommend Carolyn and her team more.
Yeah. Yeah, it comes up constantly.
constantly.
Mm.
Yeah, 1-800 my options is you go to. Mm.
The brand is safe. Yes,
Mhm.
thank you. Well, thank you very much for that
Yes.
great talk. And I certainly can recommend that book, albeit American. Yeah, it's very, very good. So our next item on the agenda is to talk or give a little bit of an update on the marvelous recent news about deregulation of the MS two-step. So Kath, would you like to speak to that
Yes.
and the kind of questions we're getting? So there's been a lot of excitement about it. and
Yes.
A lot of
A lot of
concern.
excitement. Yes, a lot of excitement since the 1st of August, and then a lot of confusion, really. Even though we've read Spears' posts and we've read the TGA media release, but it sort of it just added a few more questions. And when Patty and I looked at the Abortion Law Reform Act, I suppose for me, I really thought that the changes required also legislative changes, because the law under Section 2 talks about a medical practitioner being a prescriber. Anyway, so I just did a bit of researching and was interesting. All of the channels of communication went round and round in circles, and even, people's media releases all use the same sort of data, source of data. But today I had a conversation with the Health Department, and in particular the people from the Drugs, Poison and Controlled Substance Act from 1981, who assure me that legislative change is not required. And in terms of the increase, so here I should have said that here we're talking about nurse practitioners and endorsed midwives ultimately being able to prescribe MS two-step for early medical abortion. And so, yeah, it seems that legislative change is not required, and it will be up to the nurse practitioners are the most ready workforce group compared to endorsed midwives, because apparently endorsed midwives have a very small scope of a formulary that they can use, and that is in the process of a consultation will occur shortly. So it leaves nurse practitioners to be the most ready aspect of our workforce. And I actually received a Kathy, got a question? Yeah, so I'll send around a document it's an official document from the Health Department, and the quote is that the Victorian Drugs and Poisons and Controlled Substances Act from 1981 enables a nurse practitioner to use, sell or supply in any Schedule 2, 3, 4 or 8 medicine in accordance with their scope of practice. So that's the key. So in terms of MS two-step, this is including prescribing and administering Schedule 4 medicines for an early medical abortion. So they say that in Victoria, no further legislative or regulatory change is required. No more regulations is required for practitioners with appropriate qualifications and training to prescribe MS two-step. I can't see that training is prescribed, but I imagine that this now will go to the each individual organisation's clinical governance framework for scope of practice. Kath, have you got a question?
Yeah, I think you sort of answered it, because we had a lot of trouble with the definition of medical practitioner in terms of the failure to disclose laws, because it talks about medical practitioner, and we got our original opinion was that included nurses, then that it didn't. So, but this is coming from a totally different angle, so that's fantastic news.
In the Act, it does define a medical practitioner, and it's
this is the problem we had, was that like apparently a whole lot of lawyers from the education department just basically said that like we actually paid for legal advice first, and they said yes, that includes nurses. But then they got all this advice from the lawyers from the education department, and to say no, it doesn't include nurses. So I don't know, but I mean,
in the Act it says nurses can supply and administer.
yeah,
But
but
didn't they prescribe? But in the discussion today, the person
Yeah.
from the Drugs, Poisons and Controlled Substances branch, whatever they're called,
yeah,
that can include prescribe.
yeah. But I suppose it's just that definition of medical practitioner too. I don't know whether that's going to be a stumbling block. I sincerely hope it isn't. But
We didn't talk that would be an issue.
And it's really, you know, when you've got two pieces of legislation, one written in 1981, which is the Victorian Poisons and Controlled Substances Act, and the other being the Victorian law, Abortion Law Reform Act of 2000, which appear to somewhat contradict each other. That was why we really thought it was really important to get the department to really define it for us, because it had been quite there prior to that. Their press releases didn't go there about this. They just said, and now it can include nurse practitioners. But certainly we were, our executive here and our CEO were talking to advocacy groups within the government, because we really thought we were probably going to have to approach the Attorney General to get that clause looked at. And then the concern, of course, is if they start looking at one clause of the 2008 Act, you know what will happen. It'll turn into a, you know, another politicized media issue. So there was a lot of conservatism within government about not actually coming down on it. And this is what we've had today, which is great. They also say that they issued this in August to all the hubs and all the community centres, and we've got some of you represented here today, and we wondered, did you get that message? What was your take on it, Lou? Or Marianne, what had you been thinking?
So I've been away for 2 months. So I've been up in the Kimberleys and only arrived home mid-August, and at that stage came back to work with some significant changes in our senior management, including our direct manager. So I'm fairly sure that potentially there's an email sitting in an inbox that the person is no longer working for our organisation. So I shall I shall find if anybody's got access to, I don't know that.
And I'll get it around to the nurses and nurse practitioners in the hubs as well.
Yeah,
but overall very positive. I don't know, did you want to add anything, Danielle?
Yeah, so I just wanted to add that with the creation of the new Victorian Women's Health Advisory Council, there is a subcommittee being set up that's looking at LARC and abortion access. And I don't know if I'm supposed to say, but I think it's going to be one of the first cabs off the rank to be talked about. And it would be good to utilise that vehicle as a way to get some concrete kind of dissemination and reassurance out into the community. So it might be good to better understand who's been involved in the discussions in the department, and who has the capacity to kind of, I know you've got written communication, but to make a public statement about it, to reassure that it is within the able to be undertaken within the legislative framework of Victoria.
Because we don't want this to turn into, you know, a standoff with the AMA, for example.
Yeah, and I think the AMA would need to be reassured by some kind of public statement that's on some website somewhere for all to see, and not just kind of personal communications.
Yeah, oh, this has got the word official written on it, and Victorian government, but it's the first we've seen of it.
It's wonderful that you've been able to do that and get
Well,
that.
I was told it
You
was
really
sent
have to
around.
pick- You really have to pick at them.
Yeah, it was about, I got back to the health department after about my 5th contact, within the network. It was interesting how it just went round in a circle. But also I'm just curious in this notification that they talk about appropriate qualifications and training to prescribe MS two-step. So presumably that's a MS Health e-module.
Well, they can't actually regulate that.
No.
So because it's been deregulated at a national level, it's kind of up to the disciplines themselves to incorporate into curricula and propose, appropriate.
Yeah.
Because the ANF will probably get involved in the College of Midwives. But I have not heard of anyone trying yet and being rebuffed from the Streamline service, but I haven't heard of anyone trying yet as a advanced midwife or as a nurse practitioner yet. So we have
the other kind of roadblock is often around insurance and whether insurance will pick it up. And I just wonder if there's any way to understand that. And I'm not sure. I know what happens with GPs, but I'm not across what happens with nurse practitioners and endorsed midwives outside of hospital settings. And is that something that their professional organisation that they're working for?
Yeah, I have a feeling that would stick with the employer, but again, we should.
But have you got any experience of that, Lou or Holly? I don't know if you've been involved in this area at all.
To tell you the truth, no, I haven't really explored that. I suppose I was just kind of waiting, like a lot of people, waiting for the legislation to be really clear, and therefore, everybody on the same page, and therefore organisations such as ours and my insurer then to acknowledge that. But I certainly will have a conversation with my insurer. Yeah, there's a lot of nurse practitioners I know that have a variety of PI companies that support them. Yeah, and then a lot of nurse practitioners use the Australian Nursing Midwifery Federation too. So it'll be interesting to see if there's differences, because I remember when GPs started doing IUDs, a lot of the insurance companies differed, and a lot of our GPs here in Bendigo had struggles with their insurance companies. So yeah, I can't really comment on. We'll explore that because that's very interesting. Thank you, Danielle.
But it's interesting, Louise, that you have, as a nurse practitioner, you do prescribe other controlled substances.
Yeah, that's correct.
And your insurer covers you for that. And
yeah. So there's training for that, S100.
Training for that, and so we're turning MS two-step or mifepristone into a drug like any other.
Yeah, that's right.
The campaign was. If you're allowed to do it with other drugs, I suspect that will be a really strong argument that you won't.
Yeah, certainly. Others in the same level. Yep.
So, but there's a lot of, the devil's in the detail, and it was supposed to simplify everything. I think we might need to do a secondary campaign of maintaining the simplicity, so people don't feel that it is actually more complicated than it needs to be. And so at our next meeting, we'll do a follow-up on all of that. And as Danielle says, there is a high-level consultative committee being established on this. So I think that that will be a very important place to spend. We don't have very much longer, but we traditionally finish up with going around the group and hearing any news or things that are happening in your area, or any concerns or an interesting case. If anyone has anything that they wanted to bring up or any news to share?
I just wanted to ask a question of how other people are going in relation to the Marie Stopes nurse on call, or whatever you call them, not being available anymore, and how people are going with that, and whether that's affected 1-800 My Options. Are you getting more calls post termination? And how are people dealing with that in their service?
We've had a
So far.
couple of people not knowing who to call for support during or after an abortion, and just kind of feeling like they're getting the runaround from a few different services.
Yeah, I'm finding it really tricky as to, what to do for patients, and I feel I'm a bit concerned that they'll end up in emergency departments and not be treated very well. If they ring the general nurse on call, we might get pointed in the direction of an emergency department when it's majority of the work they did was reassurance. I think when we spoke to them, it was about, 79 or 80% or something that they said their phone calls were reassurance and not having to direct anybody to ongoing care. And it just, as someone who works on a Friday, it's and most of the prescribing for abortions, they're having them over the weekend, and just not having a backup service over that time. I'm just wondering if anybody else has any ideas, or if that's being discussed.
I can contribute here. Health Direct is an option for directing calls to, and I've had a couple of meetings with them over the last 2 or 3 weeks. They have upped their information online around medical abortion as a result of deregulation, and we've offered them to also get their clinical staff on OzCaps to try and support them more through that, and we've also offered them training to deliver to their clinical staff. So they contract out, so they have to get their contracted staff to avail themselves of training. So it may take a little bit of time, I think, to get them trained up to the level. But as they pointed out to us in the discussions, they've been taking abortion calls anyway, on top of the 24-hour hotline. So it's not something that's entirely new to them. And Marie Stopes have also passed on to them, their patient information booklets and all of the kind of red flag information about, whether your bleeding is normal and what to do in various situations. But I tend to think that we really need to stress to GPs and prescribers, to utilise the materials that is available to help their patients in kind of assessing how their response to the medication has been, because ultimately what's going to be on those phone lines is exactly the same as what's kind of given out to the patients, as part of the prescribing consultation.
Certainly, Siobhan, we here at the Women's really noticed over the last 3 or 4 years as the proportion of early medical abortions being done in the community has risen, that the number of patients being sent in by GPs who are fairly new to prescribing, or patients themselves who've had no previous experience, just turning up at our A&E department, and that was going up and up and up way before nurse on call stopped. And I suspect that it's about a critical mass and an experiential thing for GPs, that initially they're more worried about the complex of persistent bleeding and they tend to investigate them all. And so it is about educating the providers, and there's a lot of work still to be done about that. And it's kind of a symbolic move that, you know, it's a normalizing move to remove the nurse on call provision from Maori Stokes. But I don't think it'll be the crisis. I don't think it'll be a crisis because we're already seeing that. And then now trying to really educate the teams at A&Es so they don't overreact as well, and educate GP trainees and ONG trainees and get the message out there that normalizes this bleeding pattern. But you know, that's one of the challenges, isn't it? But any other comments or news or new team members? Or
I was just going to mention that Sunraysia Community Health Service has been
yes, a hub.
announced as a hub, which we sort of always thought of them as a hub, really, but now they've got some money attached to hub status. So we'll welcome them aboard.
Yeah.
And Carolyn's just put in some resources because, of course, it's September, isn't it, Carolyn? Actually, Carolyn, do you want to announce your
just
International Women's Day
Yeah,
event?
and your
the International Safe Abortion Day.
and your
Thanks. Yeah, I just dropped in the chat. We've got a new zine for September. It's really great. Check it out. And also an event coming up for International Safe Abortion Day. It's in Melbourne. Sorry to the rural folks. It's a film screening of Grandma, which is a fabulous film, and a panel discussion with Fiona Clementine Ford, Kath Bateman, who's one of the hub nurses, and Dr. Ruth D'Souza about abortion in Victoria. So check out the links and I hope we can see some of you there.
Great.
sounds
Just
great.
$10.
That's a great event. Get down there, as many of you as can. It's now exactly 7 o'clock, so we will close the meeting, and you will get a reminder, but the next meeting will be scheduled for 21st of November. Our final one for the year.
Final one for the year.
So keep on asking us questions, giving us feedback. We love to hear from